Welcome to Insights, brought to you by Manatee Cancer Center. Insights is a multi-series podcast of cancer-related subjects, giving perspectives from specialists and cancer patients as they tell their real-life stories of victory, such as Sharon.
I'm Sharon Blake, a breast cancer survivor. I want to share my story of the most challenging and rewarding journey of my life. I hope you find these podcasts full of wisdom and inspiration.
The complete Insights series may also be viewed at manateecancercenter.com. Welcome, everybody, and thank you for tuning into our series of podcasts as it concerns cancer and a number of important topics. And I'm joined today by three wonderful folks. We have Sharon Blake, who is a patient of our two doctors who are with us today. We have Dr. Yallappa Nadiminti, and we also have Dr. Mary Koshy. Welcome, everybody, to the show.
Thank you.
Thank you.
It's a pleasure. Why don't we start by talking to you, Dr. Nadiminti, about your background as a medical oncologist with the Florida Cancer Specialists. Tell everybody a little bit about your background.
I'm a medical oncologist. Medical oncologist is somebody who takes care of the cancer patients, and they are involved with the diagnosis, treatment, planning, and subsequent follow-up. Mm-hmm. And I have been in this field for 30 years. And I have been a part of Florida Cancer Specialists for the last 5 or 6 years. And the Florida Cancer Specialist is one of the largest private oncology practices in Florida. And I have been involved with Sharon since her diagnosis. Mm-hmm. And it has been a great pleasure to take care of her.
I bet. She's a delightful person, and we will be discussing some things with Sharon in just a moment. Dr. Koshy, would you please tell everybody a little bit about your background?
Sure. I'm Dr. Mary Koshy. I work at the Manatee Cancer Center. Like Dr. Nadiminti, my area of expertise is on oncology or cancer care. However, I'm a radiation oncologist, so our specialty area of expertise is in determining the need for radiation therapy and also in delivering that radiation therapy for all kinds of cancer patients, whether it be lung cancer, prostate cancer, breast cancer. Breast cancer is one of the more common cancers that are treated with radiation, and so we do see a lot of breast cancer patients. And I also had the pleasure and privilege of being able to take care of Sharon during her journey with breast cancer. So I'm excited to be here.
Outstanding. Well, thank you all for being here. And of course, this is Sharon's Insight. This is actually a series of podcasts. We call it Sharon's Insight because Sharon, this is sort of like your brainchild to put this whole group of folks together. They're going to have a series of these. Tell us a little bit about what the impetus was for starting the podcasts and a little bit about you.
A little bit about me.
Mm-hmm.
I wanted to give something back. When I had my surgery, I had my 6 weeks off, and then I went back to work and I worked through my chemo and radiation. Mm-hmm. And I was bald as a badger, and I loved it. Mm-hmm. I really did. And I just wanted to give something back because I talked about it to everybody at the hospital.
So you work actually, tell them where you work.
I work at Manatee Memorial Hospital. I work in the critical care unit. I'm a unit assistant there. So I have contact, not so much with patients, but with patients' families, what they're going through. Mm-hmm. And, I give everybody a hug if they need it, you can tell.
Right. You're the resident hugger, as I understand it, right?
Yes.
Okay.
Yes, I'm the resident hugger. But I'll hug anybody, so.
for any reason at all?
Yeah,
okay,
great,
if
you're looking down, I always offer, do you want a hug? So, but
yes.
I was very fortunate, mm-hmm. very fortunate. I had some wonderful doctors.
Yes.
And I tell everybody, 2011 was the worst year of my life, but it was also the greatest year of my life.
Can you talk about that a little bit more?
Yeah. The year before 2010, I found a lump.
Okay.
My primary care is Natalie Borg, and she said, let's go for an early mammogram. Mm-hmm. And because there's a lump, they give you a mammogram and an ultrasound. So I did that in October, came back benign. Okay. Even though there was like a golf ball-sized lump in my left breast. Mm-hmm. And then I went back to her in December for my regular checkup. She said it's got bigger. She's go for another ultrasound. Went, nothing. Yeah.
Okay.
And then like 2 weeks later, I was in pain for a whole day.
Okay.
And I saw one of the...
Were you in pain in that particular area?
Yes.
Okay. Okay.
Nowhere else, just for one day.
Okay.
And then the next day it wasn't there.
Huh.
Yeah, and then I saw my surgeon, Dr. Hassan.
Okay.
He was on the floor in the hospital. I told him what was happening, and he said, come in the office, and this was on a Tuesday. Following Monday, I had a biopsy, and then it was the following Friday that he told me it was cancer.
So I just want to jump in for a moment here with Dr. Nadiminti, as far as when Sharon was talking about when she was first diagnosed that it was a benign tumor, and of course over some fairly short period of time it ended up becoming something other than that. Talk to us a little bit about how that can mutate or change in such a short time.
Sure. The biopsy is something that you sometimes get just outside of the cancer area. So you could come out with a biopsy and it may say benign or non-diagnostic.
Okay.
And in that situation, it doesn't necessarily mean that it's not cancer.
Okay.
The mutation did not happen within the matter of a few days or a few weeks. It's there. It's just a matter of the sampling, where you did the sample.
Okay.
So whenever there is enough suspicion, you should not take that as benign and let it go.
Okay.
So if there's any concern at all, either because Sharon feels that there is something there we need to go after, or if the mammogram or the ultrasound says that there is something here, we should not settle for the first biopsy saying it's fine, let's leave it alone.
Right.
We have to go after.
Certainly, of course. Dr. Koshy, also another thing maybe to consider for ladies is, again, when they do check themselves regularly, first of all, how often would you recommend that ladies, should they do that on a daily basis to check for lumps and those kinds of things?
You can do it on a daily basis. We usually recommend it's at least done on a monthly basis.
Okay.
You know, at least once a month in the shower or at some other designated time to do a self-breast exam.
Okay.
So there has been controversy in the media about the utility of doing self-breast exams, but you know, it's our belief that it's still a good thing to do because many women do find lumps, you know, in their breasts that aren't necessarily detected by imaging, or it may be a long time before they see their physicians for, you know, a routine breast exam.
Right.
So self-breast examination is still being recommended.
Certainly, and as you mentioned about imaging, I know there's a huge controversy in that to me, I'm a little baffled by it. Again, if you can detect it earlier is always better, as they say.
Right.
What are your feelings about that? How often should they be taken? Is it once a year or once every 2 years, or depends upon family history? What is dependent upon that?
There are a lot of factors that go into determining how frequently. I'm certainly with a positive family history, you know, screening should be done at an earlier age, and potentially with other diagnostic modalities such as MRI. But typically, mammography is still being recommended on a yearly basis.
And starting at what age, if there's a family history potentially?
If there is a family history, it can be as young as 25 to 30 years old, I believe.
Sure.
Typically, for a general population, the recommendation would be at age 40.
At
so
40,
if
okay.
there is no history whatsoever, at 40 you have to start.
Okay.
If there is a family history, typically what we recommend is 5 to 10 years before the family member who got the breast cancer. So if within the family, if there was a woman who got the breast cancer at the age of 35, the sisters and the daughters, they have to be starting the screening at 25, so
Okay.
10 years ahead.
That's smart. Now, curiously, Sharon, has there been any history of it in your family?
No.
Not at all?
No cancer at all.
Okay.
No.
Interesting.
So, yeah, I've let all my nieces and I have cousins now just to get a mammogram.
Right.
So, yeah, but there's no history at all in my family.
That's very, very interesting.
Yeah.
One of the other thing is, all this time, or at least in the past, the mammograms used to be somewhat painful.
Yes.
So the digital mammograms have really gotten so much better that they're not as painful. And so the women are more willing to go for the mammograms now.
And not only more painful, but also do you feel that the imaging, as a radiation oncologist, do you feel that the imaging has gotten better with the technology improvements?
Definitely, yeah.
Okay.
I think so.
Wonderful. Now, one of the things you'd mentioned was about how it's increased in size. That seems to me like a major red flag. Not only, like you said, something that's growing in size. Do you think that was something that, again, ladies, as they're checking themselves, okay, it seems like it's benign, but now it's growing in size. Is that something they should be concerned about?
Always, yeah, okay. Definitely. If there's something that one appreciates on exam and it's growing bigger, it's something that does need to be investigated or further looked into. It doesn't necessarily mean it's cancerous, because other things can grow, but it is an indication that it needs to be investigated.
Right. Now, as I understand it, you're originally from Sarasota. Is that correct?
Mm-hmm. Yes.
And you went away to medical school, and you decided to come back. Why did you make the decision to come back to Sarasota?
I made the decision to come back to Sarasota because I love this area. This mm-hmm. is where I grew up for my whole life. My parents are here, and it's a wonderful community. Mm-hmm. So it means something special, I think, to be able to come back to your roots, to where you're from, and be able to serve your community. So
great. And by the way, for those of you watching in other parts of the world, it's Sarasota, Florida, mm-hmm. in the United States that we're speaking about specifically. And I wanted to ask you, Dr. Nadiminti, about the difference between you're a medical oncologist, and of course Dr. Koshy is a radiation oncologist. What is the difference for you, and specifically what you do?
The medical oncologist, before they become medical oncologists, they do the internal medicine.
Okay. So
you have a general understanding of all the disease processes, mm-hmm. and then you go into medical oncology. So what the medical oncologists do is mainly the chemotherapy, hormonal therapy, systemic therapy, whereas radiation oncology is more targeted to certain places.
Okay.
And the medical oncologists are involved with the diagnosis. So also the radiation oncology.
Certainly.
But the main difference is the radiation oncology gives the radiation, and we do the chemotherapy, hormonal therapy, immunotherapy, and that kind of difference.
Okay. And then for you, Dr. Koshy, mm-hmm. where would your practice lead from there?
So just as Dr. Nadiminti was saying, the primary difference between medical oncology and radiation oncology is, although we both deal with cancer patients, medical oncology, the expertise is really directed towards systemic treatment with chemotherapy, and radiation oncologists really focus on the need for radiation for cancer patients. So in radiation oncology, typically after medical school, we do either a year of surgery or medicine, and then that's followed by 4 years of specialty training just in radiation oncology. So during that time, we focus on really all kinds of different cancers, including pediatrics, and really it's studying the need for radiation, and then furthermore how to best deliver that radiation treatment. So we see a wide spectrum of different cancers, and really our focus is on determining if that cancer patient requires or needs radiation, if radiation therapy is beneficial for them in the long run. And then once that's determined, we work very closely with a team of physicists and dosimetrists to actually plan the patient's radiation therapy and then deliver that radiation sometimes over several weeks.
Okay. Now back to you, Sharon. After you got your initial report, or a little bit of a shocker. Yeah, we'll talk about that. When, of course, you first went in, I'm sure you had some concerns, and they said, no, it's benign, and you probably wiped your forehead and said, okay, I'm fine. You had that little bit of discomfort. You spoke to your doctor at Manatee Memorial.
It was a surgeon, actually.
Okay, now you just work with him, is that correct?
Yes.
Okay. What's his name again?
Dr. Hassan.
Dr. Hassan, and you mentioned to Dr. Hassan, I had some discomfort. And he said, come and see me.
Yes,
take it from there.
And I went into the office on the Thursday, and then he got all the slides up. There was nothing there, and he kept saying, this is benign, this is benign. I said, I need a biopsy.
Okay.
And then they booked me in for the following Monday.
Okay.
We went in and had a biopsy at Manatee, and then the Friday I went in to get my results, and he told me there and then that it was cancer.
Okay, so I'm going to stop you there. We're going to take just a brief moment to regain our thoughts, and then we're going to talk a little bit more about where we went forward from there.
Okay.
We'll be right back. Welcome back to our podcast, and our subject today is going to be why do you need chemo and or radiation after a mastectomy? And we're discussing our topic today with Sharon Blake, who is a patient of Dr. Nadiminti and Dr. Koshy. And welcome back once again, everybody. We left off in talking about the diagnosis. You got it. How did you respond at that point?
I was by myself, didn't expect to. I just burst into tears, I think, which most women would do.
Of course.
And everybody was nice in the doctor's office. I got hugs, and the Dr. Hassan said, everything's going to be fine. I've already booked you an appointment with Dr. Nadiminti for this afternoon.
Great.
Which kind of blew my mind. He said, I've already talked to him. Everything's set up. So when I went to see Dr. Nadi, he told me that I might have to have a mastectomy. I said no. I didn't.
But actually, you said it a bit more verbosely than that.
I shouted at him, and I apologized.
He's a very nice man, but I certainly can understand.
And I knew him from the hospital.
Oh, you did?
Oh, yeah. And I said no, because I've got a pair of big girls. I didn't want to lose them.
Of course.
And then when I went back to work the following week, I talked to a lot of people, and then one of the women that I worked with, she'd had a double mastectomy like 5 or 6 years before.
Okay.
And she sat down with me and she said it's the best way to go. And then I thought about it. I thought I'm going to get a smaller, perkier pair that's going to last a lot longer.
For sure. That's
so,
great,
we decided to do that.
Right.
And it worked out pretty good, actually.
Yeah, okay.
Yeah.
Well, wonderful. Well, now, Dr. Nadiminti, after looking at her charts and things like that and determined a double mastectomy was the appropriate approach, why a double mastectomy as opposed to, say, a lumpectomy for her specifically?
To begin with, even before we go to the double mastectomy, first we have to see what somebody needs. If the tumor is small and it can be removed and save the breast, that would be the ideal situation, a lumpectomy.
Sure.
If the tumor is large, or if it is in such a location that taking out the mass is not going to give a good cosmetic results, then the mastectomy. And there are situations where you would need double mastectomy if the other breast also shows a lot of abnormalities that you're not sure of what they are. Or you pretty much think that there is cancer there, you biopsy it, and then if that turns out to be cancer, then you will have to go for surgery on that side also.
Certainly.
Not necessarily the double mastectomies.
Right.
In situations where there is a family history of breast cancer gene being in the family or in the patient, those people have such a high recurrence rate, and more than the recurrence rate, they have the incidence of getting the breast cancer on the other side. That risk is so high, we recommend bilateral mastectomies in those patients. Okay. In Sharon's case, I am not very sure. I didn't look at her chart recently, but I think there was some abnormality on the other side also that we decided that that's what she needs.
Sure.
And the cosmetic results when you do the bilateral mastectomies and then reconstruct, I think it would be much better than trying to match the other one.
I see. Sure. That makes a lot of sense, particularly like you said, depending upon a lot of other factors. Now, curiously, for you, Dr. Koshy, I was wondering your thoughts on. Obviously, the mastectomy was what ended up being the thing. Could have been a lumpectomy. What about the possibility of chemo or radiation in lieu of either of those surgical procedures? Is that something that's ever a consideration?
Ultimately, surgery is the gold standard in removing the breast cancer. Okay. So chemo or radiation is never really given in lieu of surgery. Okay. It's usually given always as an adjuvant treatment, and by adjuvant we mean after surgery. Sometimes chemotherapy can be given neoadjuvantly before surgery, but ultimately a surgery, whether it be a lumpectomy or a mastectomy, needs to be done for breast cancer. So it ultimately the cancer has to be removed, whether it's just the cancerous lump, which entails a lumpectomy, meaning the breast is preserved. You know, with a lumpectomy, a surgeon goes in and again removes the cancerous lump and a margin around that lump. The breast is preserved, and usually it's followed with several weeks of radiation therapy. Ultimately, the entire breast has to be addressed to ensure that the disease doesn't come back. And so with a lumpectomy, that's done with radiation, and the woman is able to conserve her breast. In the case of a mastectomy, the entire breast is removed.
Right. Now, interestingly, you mentioned about radiation or chemo. What are the determinations or the factors for you, Dr. Koshy, in terms of does the patient need chemo? Does the person need radiation? And I'm sure Dr. Nadiminti also would chime in about that as well. What are your thoughts on it?
Sure. I'll address the radiation aspect, and Dr. Nadi can address the chemo aspect.
Certainly.
So for women who have a lumpectomy, meaning just the cancerous tissue is removed from the breast, a critical component of breast conservation or keeping the breast is radiation therapy. And so after a lumpectomy, the vast majority of the time we recommend radiation treatment, you know, to the entire breast in order to ensure that the disease doesn't come back. Over the past 10 to 15 years, there have been about 8 randomized trials that have looked at thousands of women who've had lumpectomy alone versus those who had lumpectomy and radiation, and they found that radiation therapy significantly reduced the risk of recurrence from about 35 to 40% to less than 10% with radiation treatment. Now there are certain cases, especially cases in which an elderly female with a small, breast cancer has favorable histology, patients such as that might be able to forego the radiation. But for most women who choose the breast conservation route, radiation is necessary after a lumpectomy.
Okay, certainly. And if you want to address the issue of chemotherapy, Dr. Nadiminti, that'd be great.
Sure. The chemotherapy is used in a lot of the patients who are young, whose tumor is large. We have a risk stratification to see, whether the risk of the cancer coming back is high or low on a particular woman, and based on that, we would recommend a chemotherapy. If somebody has a very small tumor taken out, lymph nodes negative, and older woman, in that kind of situation, we may be able to say your risk for the cancer recurrence is so small, you don't need chemotherapy. We also have another thing called endocrine therapy or the hormonal therapy. And what that is whenever we do a breast cancer surgery or biopsy, we always check the cancer tissue for estrogens, progesterones, and we check for a few other things called HER2, some of the gene protein expressions, to see what is the risk behavior of this cancer, whether the cancer is likely to be slow growing, less likely to recur, or whether this is fast growing and more likely to come back. So in those kind of situations, we decide which treatment would be appropriate. And majority of the young women, because they have so much life ahead of them, would end up getting some chemotherapy, especially if it is more than a stage 1 cancer. And the staging, again, it depends on the size of the tumor, the lymph node involvement. That's how we make the staging. And the chemotherapy is basically given to reduce the risk of the cancer coming back. The advantage of this, or the reason for the chemotherapy, is to reduce the risk of cancer coming back distantly from most of the people, when the reason we fear the cancer so much is not because the cancer is just there and we're going to have some deformity. We're afraid that this is going to come back and kill us. And that's the reason to be afraid of the cancer. And the reason to give the chemotherapy is to reduce that risk of the cancer spread to other places, the risk of recurrence. And the systemic chemotherapy does that.
Okay.
And so it's called adjuvant chemotherapy, meaning in addition to the surgery, so as an adjunct treatment.
Right.
And this is where we would give for younger women, people who have a little more advanced stage, people who have the estrogens which are negative. So those are the people who are more likely to get the cancer back. And when we were talking about the chemotherapy in lieu of surgery,
right,
we don't use that in lieu of, but there are situations where a woman has a breast cancer, wants to really preserve the breast.
Yes.
And in that kind of situation, we can give the chemotherapy ahead of time, shrink the tumor, make it small enough that it is more amenable for surgery now. Previously, you may need the mastectomy.
Right.
Now we may be able to get away with lumpectomy.
Okay. So there are a very limited number of circumstances where, as you said, if it's caught maybe early enough and you feel like you can shrink it, it still is going to need a surgical procedure. But in most instances, the surgery comes first, and then either radiation or chemo comes after.
Exactly.
And are there different levels of chemotherapy treatments, Dr. Nadi?
Yes.
Okay.
The types of chemotherapy that we use are again based on the stage of cancer and also the other characteristics, whether the estrogens are negative, HER2 positive. Based on that, we pick the different regimens or different treatment plans.
Okay.
We also pick the appropriate drugs based on what else is going on in the patient. If somebody is elderly, has heart disease and so on, we don't use certain drugs which are hard on the heart.
Okay.
Somebody has diabetes and has neuropathy, certain chemotherapy drugs cause neuropathy, and so we don't use that.
Okay.
So that's how we pick the which chemotherapy would be appropriate.
Great.
The chemotherapy also is given for people who have more advanced cancer. In that situation, its aim is a little bit different. It's to control the disease, to prolong the life. But in early stage cancer, it is to cure the cancer.
Right. Okay. Well, now, so Sharon, after your experience with the double mastectomy, of course, you were with both doctors. Was it Dr. Nadi or Dr. Koshy that recommended the next stage of treatment, which was it chemo, or what did you end up doing?
I did chemo. Didn't understand why I was going to have chemo.
Okay.
Because I'd already got rid of the cancer.
Right.
All the markers were fine. But I think it was Dr. Koshy that said if it's a certain size, they recommend it. And I think Dr. Nadi said it as well.
Yes.
If it's a certain size, it's recommended for most women. So I had chemo, I think 4 treatments.
Okay.
And then I had 33 treatments of radiation.
Okay.
So, yeah.
Right, and that's, as you said, for everything else that the doctors both described to us as far as, yes, it's been removed, but it's also, as you said, could be systemic. It could be something that could still be there that we're not detecting at this time to make sure that it's been taken care of appropriately. Please, Dr.
Sharon,
Koshy.
I know we had talked about the indications for radiation after a lumpectomy, so Sharon had a mastectomy.
Yes.
And so when women choose to have a mastectomy instead of a lumpectomy, frequently there may not be a need for adjuvant radiation because the entire breast has been removed.
Right.
But there are certain criteria after a mastectomy in which women will still need what we call chest wall radiation treatment.
Okay.
And those indications are typically large tumor size, or if there are more than 4 or more lymph nodes that are involved with cancer, that's a reason where women do have to undergo chest wall radiation treatment.
Interesting. Okay, so you went through all the treatments, and now, how long ago did all this occur?
I had my surgery February the 10th, 2011.
2011. Okay.
Yeah. Then March the 10th, I started chemo.
Okay.
And I think it was June the 6th, I started radiation. That was every day, 5 days a week.
Gotcha.
I would go on my lunch break.
So it was a little over a month.
Well, 33, so it was
okay,
like 6
weeks.
6 weeks,
okay.
yeah.
Okay, and that was in June of 2011?
Yes, finished in July.
Great.
Yeah, wasn't sick at all. I ate like a pig.
Did you? Did you?
I was planning to lose 10 pounds when I was going through chemo.
So you had your favorite turkey and cheese sandwich?
Yes.
On dry bread, or no, with butter?
My manager would walk past me at the desk and he goes, "Oh, Sharon's grazing again." All I did was eat, and it was like everybody kept saying you're supposed to be, not supposed to be, but the side effects to chemo, you throw up a lot, whatever, you're tired. But I was at work every day, 4 days a week, 10 hours a day, and just eating up a storm. I put on probably 20 pounds instead of losing it. So I was fortunate. I was very blessed.
Indeed, indeed you are in many ways, and we're blessed to have you with us. It's really, really great. And anybody who ever visits Manatee Memorial, I'm sure I'm sure anybody that's at the hospital needs a hug, and they can just look up Sharon Blake at Manatee. That's in Bradenton, Florida, for anybody that wants to travel there just for a big hug. She'll be there for you, definitely. As we're going to be finishing up here, I just wanted to make sure that folks that need to get in contact with you, Dr. Nadiminti, how can they find out more information about what you do, and website and phone number and those kinds of things?
I want to say something more before that.
Surely, please.
As Sharon was saying about the fear of getting sick, and she thought that she was going to be vomiting all the time.
Yes.
That is one of the concerns everybody has.
Sure.
The moment you say the word chemotherapy, people would say, "Oh no, I don't want that."
Of course.
And that's because everybody thinks that that's going to cause a lot of nausea, vomiting, and they're going to be sick.
Yes.
And that is not the case. We have a lot of good antiemetics which prevent the nausea and vomiting.
Okay.
And we use them routinely, not after they get sick.
Right.
We give them prophylactically. So it's not bad like they used to think.
Okay.
So I just wanted to bring that in, especially since she brought that up.
Thank you. Actually, I was actually going to ask about that. So you're saying because there have been drugs that have been developed now, anti-nausea drugs, so that in the instances like that, it's much, much less frequent. Is that correct?
Exactly.
Yeah.
Well, wonderful. Well, and again, isn't it funny? Some of the fears that we have are things like, well, I don't want to get sick.
Yeah.
I mean, I don't want to, be nauseous and things like that beyond any of the other concerns. So, well, I'm glad to see you were the.
Yay!
the banner of good eating and future good health. That's wonderful, Sharon. That's wonderful. So, Dr. Nadiminti, how can folks find out more about you?
Well, I'm part of Florida Cancer Specialists, and our website is flcancer.com. You can see everybody, all the doctors there. And our office number is 748-2217 with the area code of 941. And that's where we are.
That's wonderful. And Dr. Koshy, if you would also give us a little bit of your contact information.
Sure. I'm with Manatee Cancer Center, and our phone number is 748-4324. 941, and the website is www.manateecancercenter.com.
Wonderful. Well, this has been a really, really great session, great podcast. Thank you for inspiring us to be here with you today, Sharon. Do you have any final thoughts about it at this point, as far as this particular podcast?
I think it went well, and I hope that a lot of women will look at it and know that it's nothing to fear these days, because if you know your body and you're on your body, then there's some really great doctors out there that can help you through it, and that's the main thing. I had a wonderful team.
Yeah, absolutely.
Absolutely wonderful.
And also self-exams, you're saying, was very important.
Yeah, it was, yes.
Right. And knowing your body.
Yes, knowing your body, that's the biggest thing. When you feel a difference, you know it's something that needs to be checked out, and don't be scared to go to the doctors.
That's great. Well, don't be remember that. Don't be afraid of the doctors. They're actually here to assist you and to do those things. So we're appreciative of. Thank you, Dr. Koshy, Dr. Nadiminti, of course, Sharon Blake. My name is Mike Kradlak, and we're delighted as our subject today. Doctor, please.
I want to say something.
Please do.
One of the other things is the networking and having the other patient support is one of the greatest things, because no matter what the doctor says, the patient, especially when they come in for the first time and when they haven't seen other people who have gone through this, they don't have the same confidence in what the doctor is telling. Whereas when they see another woman who has gone through the same thing and says, it's okay, here I am. And treatment wasn't bad.
Right.
I am working, I went through this. I think that gives so much more than, all the preaching.
For sure, absolutely.
Yeah.
As you said, that personal recommendation or somebody actually saying, yes, I've been through this, I've dealt with Dr. Nadiminti or I've dealt with Dr. Koshy, and I feel a confidence and comfort and knowing that they're going to do their best to help me through this.
Yeah.
That is absolutely the best thing.
I would agree with Dr. Nadiminti. I think the most exciting thing about Sharon's story and probably some of her inspiration to share all of this is just such a story of courage and hope, and it gives hope to other women, so many women who are going through this, in our country. 1 out of 8 women have breast cancer. And and you see Sharon, Dr. Nadi, and I see her all the time when we're walking down the hospital hallways, and she's laughing and smiling, and she's a year out from, all of these experiences and this journey. And I think, many women who've gone through this will say that somehow, in a way, it may have even made their lives better. They feel closer to their family and friends, and they look at life differently. And so Sharon's story is really a story of hope and courage, and I think optimism.
Absolutely. Absolutely. Well, we're so appreciative for all of your time today and your insights. And of course, this segment is called Sharon's Insight, and this is one of many podcasts we're going to be covering about this subject. So we thank you all for being here. My name is Mike Kradlak, and we'll look forward to seeing you on other podcasts in the future. Thank you. Thank you for listening to Insights, produced by the Manatee Cancer Center. For more information on upcoming podcasts, visit www.manateecancercenter.com.